Hello, my name is Yifeng Stone, and in this video we're going to cover the vestibular assessment of the head impulse test. The head impulse test can be done without any equipment, so some may consider it a bedside examination. However, with advances in technology, we are now able to do this through video recordings and a more thorough data analysis. We'll discuss both of these in a moment. Eye movements to rotation occur not only because of vestibular input, but also visual stimulation. So consider that a moving stimulus can cause nystagmus and a strong sensation of dizziness. And if we think back to our VNG test battery, partly the optokinetic test does that. It induces a optokinetic nystagmus, and at times some individuals may feel dizzy. If we think that the neural input from those visual centers, they actually use the same neural circuitry in the brainstem as the vestibular input to help drive the eyes. And that's all located here and integrated by the vestibular nuclei. So if the visual centers are the same as those that are processing vestibular input, it raises the question of how can we purely assess vestibular function on its own? One stimulus was found to expose known total vestibular loss perfectly, and that is the early part of a brief, abrupt, unpredictable passive head movement. So by that I mean passive, so a clinician moves the client's head. It's unpredictable because the client doesn't know which direction their head is going to go, whether it's to the left or to the right. And it's a very brief and abrupt head movement. So it involves the clinician taking the person's head and just flicking the head very quickly from side to side. It could be to the left and to the left again, or it could be to the left and to the right. The idea is to make it unpredictable, as I said. The displacement is only very low in amplitude. It's just about a 20-degree movement of the head. So we need to consider that we're not doing any sort of chiropractic manipulations or making any chiropractic movements. So we need to then consider, why does this early part of that head movement make this a good test? And the answer to that is because if it's done quickly and it's done unpredictably, it is too soon for other balance control mechanisms to be able to take control of the response. So we can see here that during the early part of a brief, abrupt, unpredictable passive head movement, a patient had no eye movement response, whereas normals have perfect eye movement responses to this stimuli. And that's because they're utilizing their VOR. So to explain that further, in a normal individual who has a normal VOR, when they have their head turned, the compensatory movement would be for their eyes to turn in the opposite direction. And we covered that when we discussed the vestibulo-ocular reflex. So when the head is turned, the eyes should deviate and compensate for that head turn, and that amount of eye movement will be the same as the head movement, but in the opposite direction. The velocity should also be the same. So what we would get is that we would have a VOR of closest or exactly 1 or close to 1, where the eye and the head velocity match. In a patient with a vestibular loss, a deficit will cause the eyes to go with the head. So they don't actually make that correction with an intact, because they don't have an intact VOR. So what happens is that when their head is moved to the side, instead of asking them to keep looking straight ahead, then what will happen is that their eyes will actually move with the head, and then they'll realize that they have to make a corrective eye movement back. So if they're instructed during the test to keep their eyes on the examiner, then in a normal individual, they would be able to do that. So their eyes would be able to compensate for the amount of head turn. But in individuals that have a vestibular loss, you will see that during the rotation, their eyes will move with the head. So they'll be no longer able to keep their eyes on the examiner's face. Okay, but then they'll realize that and they'll need to make a corrective saccade or a corrective eye movement at the end of the head turn. So the eye does nothing until about 100 milliseconds later, and then it starts to move. So during this time, there is no input from the vision or no input from the proprioceptive systems. So in these individuals, what we will see is that there is actually a difference between the eye velocity and the head velocity. So what will happen is that the head will move first, and then there'll be a lag in the eye movements as it has to correct back. The key things are that we're looking for an asymmetry between the neural dynamic range of excitation versus inhibition. The other key things are that, as I said, it has to be a quick, abrupt head movement. This will help to eliminate any visual pursuit input. It will also help to saturate the inhibitory drive from the good ear, if there is a good ear. And higher accelerations usually yield a larger amplitude of a catch-up saccade, so making it easier to see. So head impulse testing has quite a high sensitivity, especially for those individuals that have a complete canal paresis or a complete unilateral weakness on caloric testing. It's more sensitive for more severe canal pareses, so when their caloric test shows a greater than 60% canal paresis or a greater than 60% unilateral weakness. Mild canal pareses can sometimes give a false negative. As I said, the test can be carried out at the bedside, so just by making observations with the naked eye. And in that case, we can see an absence of an overt saccade does not necessarily mean that there is no semicircular dysfunction, because it is quite hard to sometimes make these observations with the naked eye. The bedside version is dependent on the examiner making a visual observation of the catch-up saccade, which we call an overt catch-up saccade. Hence, it typically needs to be a very experienced clinician that is very familiar with these types of eye movements. So when you're making these observations, you need to know what you're looking for, otherwise you can't accurately interpret the tests. We also need to keep in mind that results can be complicated by any spontaneous nystagmus. So here's a video of the head impulse test.
In a normal Halmagyi head thrust maneuver, the eyes will remain fixed on a focal point despite sudden, unexpected head movements. In the event of a vestibular weakness, an involuntary eye deviation towards the affected side will be followed by a corrective saccade.
The video head impulse test, or VHIT, is the work of postdoctoral student Hamish McDougall in collaboration with Professor Ian Curthoys and Professor Michael Halmagyi. This involves the use of a high-speed camera to get an image of the eye that's reflected off a transparent mirror. Computer software is then used to calculate the center of the pupil to calculate the difference between the head and the eye velocity, so quantifying the observation made in a bedside head impulse test. There are many clinical advantages to the VHIT as opposed to the bedside head impulse test, and that is mainly that there is an increased sensitivity and specificity to the test, but also we get further information. With the bedside hit, we can only observe the corrective saccades after the head movement, so the jump of the eyes back. But actually, during these fast head movements, there can be also what we call a covert saccade, and that is an eye movement that is made during the head turn. That's not possible to be seen during the bedside head impulse test. However, the video hit or VHIT is able to actually capture this. Other advantages of the VHIT are that it's very time efficient because we can actually look back on the recordings, and it's huge accuracy as well, rather than basing it on just observations of the naked eye. So it removes that guesswork. As I said, it's got excellent sensitivity and specificity, so it can be more sensitive in picking up those milder cases of canal paresis or unilateral weakness. And we also get very high quality data analyses as well. When looking at VHIT results, we can see that in the healthy subject, the head velocity matches the eye velocity in both directions for head turns to the left and head turns to the right. Because the head velocity and eye velocity are matching, as shown by the yellow and the blue lines, we can then see that this healthy individual has a VOR gain of close to 1. In an individual with a left unilateral vestibular loss, we can see that the head, which is shown, the head movement, which is shown in the blue, moves first, and when turning towards the affected side, the eye is delayed. So the eye movements in yellow are delayed. What we can see is that they don't match up, and we can see a large spike here, which indicates an overt saccade that has happened after the head rotation. So an eye movement that's happened after the head rotation is what we call an overt saccade. On the healthy side, which is this individual's right side, we can see that the head and the eye velocity virtually match up, so that their VOR gain is close to 1 for the right side, but it's impaired significantly for the left side. In an individual that has a bilateral vestibular loss, we can see that in both directions towards the left and to the right, the head movement moves first, so the blue lines, and that we can see that there is that initial yellow bump, which is an initial eye movement, probably due to a little bit of slippage, and then large orange spikes, which show saccades, and this is in both directions, so when the head is moving. So what we can see on the VOR graph, or VOR gain graph, is that they have low gain for both directions, left and right. Here's a video demonstrating the clinical application of the video head impulse test.
While the patient fixates a target, the examiner briskly rotates the patient's head to look for possible catch-up saccades. Overt saccades, which occur after head rotation, are the telltale sign of canal paresis, whereas covert saccades, which occur during head rotation, are not detectable to the naked eye. The patient puts on the lightweight video goggles and then looks at the center of crossed lines from a built-in laser to calibrate the entire system. Now, while the patient is looking at a target on the wall, the examiner briskly rotates the patient's head to each side in random order. During the test, the examiner has instant feedback about head velocity profile and the corresponding vestibulocular reflex eye movement of every single head impulse. The examiner can analyze and discuss the results with the patient immediately, since the software analyzes the data at the touch of a button and displays intuitive 3D graphs. In summary, video goggles are easy to use in a clinical setting and provide an instant objective record of the vestibulocular reflex and detect both overt and covert catch-up saccades in vestibular patients.
Another key advantage of carrying out VHIT as opposed to the bedside version of the head impulse test is that it is much easier to get data analysis on all 6 semicircular canals. When making observations using the naked eye, it's very difficult when the head is tilted because it's hard to see from an examiner's point of view standing in front of them what happens when their head is moved down and their eyes move up in the opposite direction. So with the use of the video goggles, we can see that eye image projected on our computer, and the computer will do the analysis straight away, and so we get immediate feedback on each of the 6 semicircular canals. Just to remind you, going back to the anatomy of the semicircular canals, remember that there is a paired relationship between the left horizontal and the right horizontal canal, that those two work together. The left anterior and the right posterior, using the abbreviation of LARP, are paired together, and the right anterior and the left posterior are paired together to give us that pairing. So just demonstrated here, the RALP, right anterior and left posterior, lateral, so your left lateral and your right lateral, and on the other vertical plane are your left anterior and your right posterior of the LARP. Here is a result of a normal individual, and you can see that they've got equal head velocity to eye velocity on all 6 planes.